Good evening, all. I think we'll just start about the webinar. So, as we all know, DNAs are the building blocks for life as we know it. Genomics, the research, is the future of medicine. And targeted gene therapy is a cutting edge technology that can potentially be curative in diseases which we were thinking that could be untreatable. And untreatable. So nowadays, this can allow newer ways of treating these patients. Gene-based treatment can allow us to treat, predict, and manage the prognosis and the natural course of the disease. So we have Dr. Parveen Sen, madam, who is a very renowned vitreoretinal surgeon and pediatric retinal surgeon, and she has a special interest in hereditary and non-hereditary retinal conditions due to her experience in working with the electrodiagnostic services when she was in Shankar Nethralaya. And she's a internationally renowned person. We are happy to invite her as our panelist for today's session. And let me introduce to Dr. Senthil Kumar, who is going to be the speaker for today. And he's currently with MedGenome after having 12 complete years of experience in molecular cell biology, genomics, and he has worked in various renowned organizations at various levels, as in biocon, genotypic technology, life technology, and currently he is with MedGenome. So now I hand over it to Dr. Senthil to go ahead with the topic of role of genomes in ophthalmology. Dr. Senthil, please.
Yeah. Good evening, all. So I am representing MedGenome, functioning in the scientific affairs lead for the inherited genetic conditions. So today, respected faculty members and for the Dr. Agarwal Hospital, thank you very much for giving MedGenome as an opportunity to create awareness on these different genetic testing is available related to ophthalmology related eye conditions. So initially we were in discussion with clinicians at Bangalore at various levels, and finally it is materialized to the level of having a small session today. So today I will try to address what are the different genetic testing methods available which we are doing at Genome for a different kind of conditions. And I will try to show with the kind of small model cases which we happen to handle at our laboratories to showing us a model cases and how it will be helpful in disease prognosis and even prevention with the pediatric conditions, how they can plan if there is a positive kid in the family, how they can plan to have the normal child, second normal child during the appropriate prenatal testing and all, they can go for it. So genetic testing is actually, it's a very complex and advanced topic where I will try to today create some basic awareness. As I mentioned, so MedGenome Lab is based at Bangalore. We go about using the different molecular techniques, such as next generation sequencing, microarray, and PCR-based techniques we are using to analyze and diagnose the genetic conditions. We are not only involved in clinical diagnosis of the routine clinical samples, but we are also taking time to time the cohort research projects in collaboration with multiple Indian institutes such as Indian Institute of Science, Center for Cellular Molecular Biology in Hyderabad, and even some hospitals like National Institute of Mental Health and Neurosciences in Bangalore, kind of things. So we do the multi-sample research projects also with respect to genetics and genomics. So coming to rare genetic conditions, if you look at the literature, they are talking about around 5,000 to 6,000 rare disorders. In that, more than 80% are genetic in nature. This is of particular importance when it comes to South Asia and more importantly this Bangladesh and Indian subcontinent, which is very relevant because the consanguinity is as high as 20 to 30%. even not only the known first degree, second degree consanguinity, but also the endogamy. Still, we are a population of, encouraging intra-caste marriages. So endogamy is one level of distant consanguinity. So they say call the India's, hotspot for studying, genetic diseases. All these communicable diseases are fought with vaccines and antibiotics. So now this rare conditions prevalence is being felt, and their importance are now being addressed. So individually these disorders may be rare, but cumulatively there are 5,000 such conditions, and cumulatively it accounts to around 8 to 10% of the cases, which if we have to extrapolate in terms of population, it leads to around 80 to 100 million cases. Vast majority of cases are reported in India because of the population and also the high level of consanguinity. So if you look at the ophthalmology related conditions, again, in that 5,000 rare conditions, 1/3 of the rare genetic conditions involve the eye related abnormalities. That's around 1,000 to 1,500 rare genetic conditions will have one or other eye related, going to have eye related abnormalities. Either it could be isolated eye related event, or it could be multi-system event involving eye, like a syndromic presentations. So most of even the metabolic deficiencies, the pediatricians and pediatric neuro, routinely we deal with them, actually have one or other eye-related complexities, the inborn errors of metabolism, which are generally known as. It is going to have the eye involvement. And also more than 60% cases of pediatric blindness can be attributed to one or other inherited eye-related conditions, which could be inherited retinal degeneration, or it could be congenital cataract kind of conditions. So such is the prevalence with respect to ophthalmology also. And when it comes to using this genetic diagnosis practice in routine, there is a lack of limited genetic literacy is there, and lack of perceived benefit. Even the sometimes the clinicians also feeling that it is a genetic conditions. I know that why to go for testing it out. What is the benefit? Anyway, there is no cure. So such kind of feeling is prevailing. And also the cost involving with this testing is, of course, a major concern when we deal with the grassroots population in India, because this testing is involving with the cost, and no insurance company is also, taking it genetic testing under the policy coverage. So these are all the issues when dealing with genetic disorders, and the most importantly, the availability of the pre-test and post-test counseling to the family. So we need to have we generally conduct in MedGenome, we do offer this genetic counseling of half an hour to 1 hour sessions to the needy patients, actually, even before going for the testing, why this test is important to their family, how it will be helpful in understanding the prognosis, and more importantly, how it can help them getting the normal child if they have one positive child in the family. So these are all the things. And when it comes to ophthalmology disorders with respect to genetics, we categorize in the following manner. One is that monogenic conditions, which are typically, for every gene, there is a disease association, gene disease association. So if there is any mutation identified in the gene, and that individual is going to, clinically manifest one or other these conditions, say for example, retinitis pigmentosa or Leber congenital amaurosis, retinoblastoma. These are very well characterized genetic disorders. When you talk about retinoblastoma, there is a RB1 gene mutation, as you all of you might have heard. Same way, retinitis pigmentosa, a lot of subtypes, and each subtypes there is one gene is associated. These informations come from the vast majority of the literature done over the period of time, and vast majority of the cases presented previously. So from the advancement of the sequencing technology, we were able to associate typical genes to the typical conditions. So these are known as monogenic conditions. So there is a gene and there is a causality clearly associated, means RB1 gene mutation, and there is a clear-cut establishment to the retinoblastoma. When it comes to developmental disorders, it is multi-system, not only a single gene involvement, but also, chromosomal level causes, aneuploidies, congenital malformations, can be attributed to multiple anomalies in the DNA actually, not only just a single gene mutation. For us, such as coloboma kind of cases, we can do, a lot of chromosomal level deletions and duplications or aneuploidies can also lead to that, along with certain gene involvement. So such as aniridia, developmental disorders, anterior segment dysgenesis kind of things. But whereas these two conditions are rare, whereas there are certain conditions are called as commonly occurring complex conditions for which there is no proven genetic etiology is available. There is no single gene we can attribute to that particular condition. For example, congenital cataract in a pediatric level can be monogenic, but late adult onset cataract is not a monogenic. The same way the other frequently looked at cases at the ophthalmology clinic is your AMD. Again, it is very complex, proven monogenic etiology. So this needs to be dealt with differently. We can only understand the inherent genetic risk predisposition, but not exactly, we cannot identify the causality. For all these things, the causality can be established if we do the proper genetic testing at a very early level itself. So that's the difference between the rare variants linked with the monogenic conditions, whereas multiple genes and multiple variants, linked to the cumulatively linked to the common complex disorders. Even you can attribute this to your obesity, diabetes, and stroke. All these things comes under these complex conditions. With regard to ophthalmology related, the most common ones are this cataract and AMDs. So coming to a little bit of textbook molecular biology, some of you might aware, but just to give for the non-initiated, so we all have this 3 billions of sequences in all our cells actually. So whenever there is a error happening, which is called as error happens in the DNA as told in the introduction, but when these errors happens in the key important genes, which are implicated in specific conditions, then the disease manifestation is going to be there. So we all are having this kind of chain of sequences. Let's say this is the reference normal sequence. So in anywhere in this chain, if there is going to be some typo errors kind in analogy, like a base G, we all, you might be aware this DNA is made up of ATGC. Okay, so whenever there is a change, G is changing to C or A is changing to T, something like that. Sometimes even one of the base may get deleted also. Sometimes extra two bases can be added, which may disrupt the particular protein expression coded from the gene, and thereby it is going to which in turn is going to affect the normal physiological function of that protein, which is supposed to attributed to that, which is going to be affected, and thereby the clinical manifestations. So these are very broadly we can call it as errors in DNA, and these errors can happen at a very small scale level, such as this one, or the errors can happen at very large scale level. So if I have to draw one simple analogy, if you take a book with 23 chapters, let us associate to the 23 chromosomes, which we all have. A complete loss of one chapter or duplicating a particular chapter is either known as monosomy or trisomy. If I just remove 2-3 pages alone, and that will be called as large scale variations, or otherwise known as copy number variations. If I just remove 2-3 pages like this, it is not there here, then it is called as copy number loss. If I added 2-3 pages more, like it is called as copy number gain. So in our DNA and in the at chromosomal level also, this kind of large duplication events or deletion events can happen. Whenever these duplication events or deletion events happens over multiple genes or involving a particular gene, then it disrupts the physiological function of the protein. So your DNA level error can be either simple typo errors such as this, or it could be of a complete block of sequences getting deleted or added. So multi levels of error can happen. So that is why we have the multiple testing methods also. There will be no one testing method can identify all possible errors as we shown here. Okay, so that's why I'm saying the different testing methods is available according to test to the different level. For example, this is the karyotyping, which all you might aware in the past decades and all everything. The molecular testing means first they will go for a karyotyping only, which is largely implicated in chromosomal level aneuploidies for Down syndrome to detect the well-characterized Down syndrome, Edwards syndrome. These are routinely now screened for aneuploidies at prenatal. In all the pregnancies nowadays, they are going for this prenatal screening for aneuploidies. And to detect this chromosomal level variations, you can go for a karyotyping. In terms of DNA base pair resolution level, it is 5 million bases and above variations you can detect by karyotyping. Just you can observe under the light microscope and you typify the same. But whenever it happens at sub-microscopic level changes, such as these kind of changes, which is involving some 1,000 bases or 2,000 bases, 3,000 bases, then you cannot detect just by observing under microscope in the metaphase chromosomes. So those are known as sub-microscopic level, for which we resort to the technique called microarray. So such as coloboma under this chromosomal level, micro deletions and micro duplications is reported. Large DNA deletions and duplications. So to negate with that kind of errors, you need to go for this microarray method. And to the further high resolution level is your level 4, which is at single nucleotide levels. That is this first line, typo errors. So this kind of single gene, single base changes also known as leads to disease causing, which are known as mutations, can lead to the disease. Okay. So to detect this kind of typo errors, we go for this next generation sequencing method. So we use multiple methods to detect different kinds of errors which can occur in the DNA. It can occur at the major macro level, chromosomal level, or it can occur at the very single base levels also. So different conditions are well studied and attributed to different levels of aberrations. So that's what I'm trying to emphasize here. I would like to introduce a brief genetic concepts, which are general. It's not only to the ophthalmology, but also for all the genetic conditions, these concepts are common actually. So when we are dealing with genetic conditions in your clinic, the first thing you need to have this at least 2 to 3 generation pedigree, which is going to be very helpful. So in terms of genetics, we categorize the disorders like recessive conditions and dominant conditions. As you can see in this pedigree, which is I'm showing 4 generation pedigree of one family. This characterized recessive conditions will manifest whenever there is a 2 copies are mutated. As you all might aware, for each gene, we have 2 copies, which are known as alleles. So when both the alleles will become defective, then only the recessive conditions will clinically manifest. Those are otherwise known as biallelic mutations. In genetics, we call it as a homozygous mutations. Okay, so what happens when we deal with the recessive conditions? The parents can be completely normal, actually. They generally, they will be asymptomatic carrier or silent carriers, but it will suddenly appear in their offspring, actually. So all the recessive conditions can appear both in males and females equally, it appears. But the characterization of the recessive conditions is such that it can skip generations. Suddenly in one generation, everyone will be completely normal, but it can reappear in the 4th generation because of the consanguinity involved in these parents. So this is the characterization of the recessive conditions. Some of your ophthalmology conditions can be, recessive or can be dominant. That information comes from the previous gene and the literature, what conditions are associated with. Here I am showing one model case of recessive conditions, which we happen to deal with at MedGenome. This was a case of, 42 years old female with non-consanguineous marriage, and optic atrophy and retinitis pigmentosa was the clinician given clinical handles to us. So when we did the multi-gene panel genetic testing, and then we found this mutation in DNA in the gene, GUCY2D gene actually. So which is likely pathogenic, means this mutation and this gene is previously implicated in Leber congenital amaurosis, pathogenic variant, and you see it is a homozygous. As I said earlier, the recessive condition is characterized by two mutations in the same gene. Biallelic should be there. Generally, parents will be heterozygous and offspring will be homozygous. So typically when you send a sample with a suspected genetic etiology for genetic testing, you are going to get this kind of report where it will tell about what kind of genes and what mutations involved and what is the inheritance patterns and conditions in the literature it was associated with. Then you have to, you reverse phenotype whether the given condition is matching to the your clinical indications of your case. So that is what we call it as a genotype phenotype correlation. So how do we go about doing that? Is that for each and every genetic conditions, there is a phenotypic characterization actually. So which is called as online Mendelian inheritance in men database. You go and you type this Leber congenital amaurosis, then all the phenotypic literature characterized phenotypes will come down menu. Then you evaluate your index case and you phenotype it, whether all these features are, observed, such as central vision loss, cataract, photophobia, nystagmus, everything. And you can see this gene is also associated with Leber congenital amaurosis. Now, you have got this crucial finding for this case. And that is how we go about, confirming your clinical diagnosis, or this is how we go about establishing the, genetic diagnosis in the index case. You see, as I mentioned here, it is a homozygous mutation. So generally what will happen, her parents of this index case will be heterozygous for the same gene. So whenever there is a recessive condition, there is a 25% of recurrence risk for the offspring to receive, because each parent will contribute one defective copy. When both the defective copies comes to this individual, and that individual will clinically manifest. So in this case, it is Leber congenital amaurosis. It was the clinical diagnosis, and genetically also it was established. So this is another example. We happen to deal with another autosomal recessive condition. It could be your chondrodystrophy or retinitis pigmentosa 65. Again, you may clinically diagnose at your clinic also, it is a retinitis pigmentosa. But why the genetic testing is important is that, as you also might have heard, there are a lot of subtypes characterized for retinitis pigmentosa alone. As you can see here, it is retinitis pigmentosa 65. For different subtypes, different molecular causality is associated. And the inheritance patterns and the prognosis is differing. So that's why even though you are kind of clinically narrowed down to it is retinitis pigmentosa, you need to test it out, what exactly the subtype and what is the gene involved. So because these are all rare disorders and it is going to vary family to family. So in this case, we happen to detect it is present in the CDHR1 gene, and this is the mutation. So when you deal with the genetic report, we give this gene name and what is the location. Basically, this is like the mutation address. Like every house has an address, like a door number, street number, and the taluk and all these things. Like this, so we have a 3 billion bases of DNA. So how there should be one universal method to denote the mutation position. So that's why we have this exon locations, and this C dot position is that position of the mutation where it occurred in that gene. And this is the protein change. Whenever this mutation occurred, that deletion occurred, because of that, in that amino acid protein gene was, the chain was not continued. It leads to frame shift termination of the protein. So this CDHR protein will not be expressed properly. When there is a both defective copy is there, homozygous mutation, which leads to loss of function of this CDHR1 gene, which is the molecular underlying phenomenon for your clinical phenomenon of retinitis pigmentosa. So understanding this is helpful. Why? Because you are understanding that for this family, it is going to follow the recessive pattern. That means 25% of recurrence risk. And this is the gene. What is the exact subtype also you are confirming in this. Another characterization when you deal with genetic conditions or autosomal dominant disorder. So you see this pedigree here. In each generation, there is one affected individual. That means this subset of clinical conditions is going to manifest even if one copy is going to be mutated. Those kind of conditions are known as autosomal dominant conditions. In contrast to your recessive conditions where two copies should be mutated, then only the individual will clinically manifest. So that's why the recessive condition, as you see, it can skip generations, because most often we all are in one or other way carrier for some pathogenic mutations, but we are escaping from those rare conditions. But when it comes to dominant conditions, there will be clear positive family history will be there. If you ask them maternal side and paternal side, they will tell, yes, my father is affected, my maternal uncle is affected. One or other history they will tell you actually. And you can see this index cases will have affected one of the affected, at least in this is in theory. But what happens in practice, we do see dominant conditions without seeing the parents symptomatic. So those are known as de novo sporadic incident, actually. So that is also documented. So in theory, of course, autosomal dominant conditions, they have affected father or mother, but in practice, it need not be. So by looking at the pedigree, it may look like a recessive condition to you. By looking at the parents are clinically normal, but it could be still autosomal dominant sporadic event in that index case. So that's why by testing the genetic testing only, you can easily understand whenever there is no complete pedigree not available. So you can understand autosomal dominant pattern also. Because already we know there is a literature, PAX6 gene is a dominant gene only. It is from the literature we'll come to know the inheritance patterns involving in this family. So this is the case, model case for a dominant condition, which is your aniridia, congenital aniridia. This was a 22-year-old male. This case happened to us with this clinical notes to us. More importantly, the congenital aniridia was there. This fundus examination reported CD ratio of 0.6 and foveal reflex was noted. So when we test this sample by sequencing with a multi-gene panel, and we got this mutation, as you also might aware, this PAX6 gene is very well characterized and very well established in aniridia cases, and it is previously reported pathogenic mutation, and that's how you go about establishing the index case. And you see there is a positive family history of aniridia in his father. So that's why the autosomal dominant condition is going to have either of the parent to be affected. So clear-cut positive family history is there, and that also further establishes the genetic diagnosis of aniridia due to PAX6 gene in this family. That means for this family, 50% of recurrence risk. Okay, now you see this individual is 22 years old. Suppose in case if he thinks of marriage and having a family and all, then there is a chance for 50% for his son or daughter to develop this. Okay, so that's where it is going to be very helpful. So genetic counseling should be given to this individual. What is the implication? What is the recurrence risk in case if he or she planning to have a family? Because it is a 50% of recurrence risk. It's going to continue in his family with this aniridia. The same way, it's another case. So why I'm showing this, you see this also PAX6 gene only, but you see this mutation position is different. So that means this case is also aniridia, but you see here we are getting the different mutations. So PAX6 gene is a multiple bases. It has got exon 1 to multiple exons and multiple DNA sequences. Not every individual need not have the same kind of mutations which we detected in different individual. We no need to detect the same mutation in another individual affected with the aniridia. That's what I'm trying to say here from the genetic perspective. So this individual also, aniridia, we got the mutation, but different point compared to your previous case. Same PAX6 gene only, implicated in aniridia, but this mutation position is different. This case, the mutation position is different. So this you will come to know by the genetic testing only. This mutation position coordinates, what we call, is important to understand the prognosis and the future recurrence. Then only we can do the appropriate testing for the next baby. What exactly needs to be tested out, we will come to know this. So that is what I'm trying to emphasize in this case. And so this is again the family case. The father was affected, and we were able to establish in son and daughter also similarly affected. And if you can see, all of them is got this mutation in PAX6 gene. Family case again for an iridia. So same way, another model case for a dominant concept is your vitelliform like retinal lesions retinopathy, and we also got vitelliform macular dystrophy for this case when we sequence. That was the best one. It's one of the best tropathies, and it is a likely pathogenic variant we got in this case. So it's an again autosomal dominant, 50% of recurrence to the family in case he is offerings. So we have the exact mutation point on what gene. That information is a crucial information for that particular family, because these are rare conditions. Other characterization in the genetics is your X-linked recessive traits, but here we are going to see the gender bias. Generally, the females will escape from manifestations, and they are called obligate carriers, but the sons will always manifest the condition, because here the genes are present in the X chromosome. So generally the sons will receive only one X chromosome, and that should come from the mother only. So the sons will manifest the symptoms more. Here I'm not able to recollect any quick X-linked ophthalmology related condition, but what we typically get in our laboratory is your Duchenne muscular dystrophy and this hemophilias, bleeding disorders, which typically you will come across, you see affected in males actually. Some X-linked cataracts is also there. That's why clinically you may identify it is a congenital cataract, but you need to see in this family whether it is happen to be any X-linked condition, or it is an autosomal dominant or recessive conditions. For that, genetic testing is going to be very helpful. So that's why. So that's a concept. What I am trying to show is the brief concepts, and so that's how whenever there is a indications to go for a genetic testing. Basically, whenever your preclinical or laboratory findings shows that there is an underlying genetic etiology. For example, in a pediatric conditions, you may do simple fundus examination, cherry red spot. Cherry red spot indicates some of the mucopolysaccharidosis. Or your urine GCMS also shows that glycosaminoglycan subnormalities. So that means it is one of the inborn errors of metabolism. So that kind of child, you need to further evaluate the molecular genetic testing. So your newborn screening profile or simple your eye examination profile indicates some such genetic etiology. You go for a genetic conditions. Sometimes by genetic testing only you can do appropriate medical intervention. Some of the metabolic deficiencies, by doing some dietary supplements, we can actually mitigate further progressive complexities. Some of the eye-related disorder may progress to neurological involvement also. So by understanding what gene involved, you can actually go about understanding the disease prognosis and treatment, symptomatic treatment accordingly. You can take the most important thing what we more go and tell in genetic counseling session is this one: guide reproductive planning and assessment of recurrence risk. So when you have, at least with the pediatric cases, it's going to be very useful to give the appropriate genetic counseling to the family and ask them to undergo the genetic testing, so that in case if they are planning next, they can avoid the recurrence risk. Because by specifically understanding the specific mutation points, such as I have shown in those model cases, we can prenatally nowadays the tests are available. Just to go for at 16 weeks, they can go for 13 to 16 weeks. They can go for either chorionic village sampling procedure or amniocentesis procedure, and we can test the mutation, whether the fetus is, likely to be affected or not affected by looking at the presence or absence of these mutations. So this level of preventive care we can go about, provided we establish the genetic diagnosis in the index case, and which is going to be very, very useful to that particular family. And these are all the panels available. So we do have this, what we call it is targeted phenotypic specific panel. Suppose you are clinically narrowed down to retinoblastoma, and you can just like that, you can go for RB1 gene analysis alone. Suppose you are clinically, you understand it is Usher syndrome with deafness, then you can go for a Usher syndrome gene panel. But sometimes, many times, we may not clinically narrow down to the particular condition. So when there is broad spectrum phenotypes, then you go for this comprehensive ophthalmologic gene panel. So in that we cover around 700 genes associated with most of the typical ophthalmology conditions you encounter with, which basically includes all the inherited retinal conditions, your retinitis pigmentosa, Stargardt disease, Bardet-Biedl syndromes. So all these things. So all these smaller panels also covered in this ophthalmology gene panel. So I would suggest you to your first line genetic testing to any inherited suspected genetic etiology condition, particularly inherited retinal degeneration and congenital cataracts. When you deal with these conditions, I am suggesting you to evaluate with comprehensive ophthalmology gene panel. So the bottom panel, what I'm showing is all the kind of big circles, broad spectrum panels, cost involving. All these subsets is included in this, actually. But this you will go for, of course, at the end of the day, it is cost versus affordability and the kind of phenotypic handles you deal with at the time of, evaluation of the index case. Whenever you deal with complex cases, like, very facial dysmorphism, along with eye-related anomalies, gross anomalies, with other multi-system involvement, like mental retardation, intellectual disability and all observed, then you have to resort to this whole exome sequencing, or sometimes even you have to do exome sequencing along with the parents, father, mother, and index trio work. So these are all the broad spectrum. You can resort to this level of genetic testing whenever there is a complexity involved. So when you deal with if you can clinically narrow down to certain eye-related phenotypes, then you go for this comprehensive ophthalmologic gene panel, which typically can help you with most of your ophthalmology-associated cases. So, so when we go about testing in our sample, we are going to follow the universal guidelines, which is provided by American College of Medical Genetics. See, the previous model cases, what I shown, the pathogenic, likely pathogenic, and all, we are doing it by following the stipulated rules. It's not our well and wish we give certain mutations pathogenic, certain mutation not pathogenic. It's not like that. There are guidelines which involves in the backend, a lot of bioinformatics involves. It's very complex analysis. So I'm not going to tell how do we go about an approach itself is a separate topic actually. But what I can tell the long story short is that we are going to follow the CMG guidelines to call a particular variant is either pathogenic variant or likely pathogenic variant. This likely benign or benign variants we will not report, because which is usually occurring in the common population also. If a particular variant occur in all the common control population also, that may not be disease causing, right? So we will not be reporting it. Those are just called as polymorphisms, not mutations. But there are some mutations which are previously reported in the similarly affected individuals, and there are PubMed indexed journals saying that yes, this mutation leads to this particular clinical mutation. That association is established, functional evidence is there, then we will call it as. Whenever there is a functional evidence is lacking, but it could be very relevant, we call it as a likely pathogenic. So this pathogenic and likely pathogenic in terms of clinical thing, it is clinically actionable for you. These two are not actionable. These two, whenever this one, whenever you get this variant of uncertain significance, we might ask you to do further testing of the family members to further understand the significance, whether it is clinically relevant or not clinically relevant. Maybe we need to work with the asymptomatic individuals of the same family, and we need to understand how this mutation is segregates. Okay, thereby we can further dissect the importance of the variants. So what we need our testing is, because all these mutations are germline mutations, which is going to be present in all the cells. So although you are dealing with eye-related conditions, what we need is just a blood sample only, because the mutation is going to be present in all the cells. These are called as germline variants, except a few exceptional when we deal with oncological cases, which are somatic in nature, where we need the tissue biopsy specimen. But for all your inherited disorders, a simple blood sample, EDTA tube, 3 to 4 ml blood sample is fine for us. And then we'll turn the report around 4 to 5 weeks. Just to quickly tell in another 5 minutes why the importance of the genetic, although I have shown some model cases, but these are all from literature information, because it could be helpful in your treatment. Why? Because the clinically it could be congenital cataract only, but by testing it out only, some of the congenital cataract is also underlying inborn errors of metabolism. So you can at least, like in this case, they did examine 115 children. Clinically, they're congenital cataract, but in 6 cases, it turned out to be one or other metabolic deficiency. So in those cases, your treatment methodology can be appropriately, you can give the dietary management. Just by doing the dietary management, you can actually, symptomatically, you can treat those children. For that, you need to understand the molecular underlying cause of the congenital cataract. Okay, so that's where the genomic testing can be helpful. The same way, if you understand in one family member, there is a myoc gene positive mutation is detected when you are dealing with the primary open-angle glaucoma cases, those families going to stand to benefit more than the family who do not undergo this genetic test. Okay, because they can go for early preventative treatment if there are myoc gene positive mutations detected in the family. Same way, when you're dealing with the condition C, most of the rare conditions, if you examine eye, the phenotype looks similar. Whether it is, further dissect, whether it is choroidodermia or soft tissue retinal dystrophy, you need to go the genetic testing. And it is, as we discussed further, it is whether it is going to follow the X-linked pattern, any gender bias is going to be there in the family, accordingly the recurrence risk. Suppose if you get autosomal dominant gene mutation, then accordingly the recurrence risk. So to dissect what is the accurate diagnosis based on the overlapping phenotypes and what gene involved and what is the kind of pattern it is going to follow the family, it is going to be useful. And that's why you are resort to genetic testing. And also another utility is that sometimes you at your clinic, you suspect something, but after testing, you might need to refine your diagnosis, because many cases genomic testing resulted in altered diagnosis because of the overlapping broad spectrum phenotypes. Because, for example, in this patient, the clinician suspected chondro dystrophy, but after testing, what we got is the Bardet-Biedl syndrome related mutations. So you take that case and reverse phenotype, whether the given gene is the actual match to the index case. Thereby, you refine your clinical diagnosis. At sometimes, your genetic testing can confirm your clinical diagnosis. At sometimes, genetic testing can help you to refine your clinical diagnosis. For example, whenever there is a renal retinitis pigmentosa with renal disease, some people tend to associate Senior-Logan syndrome, because Senior-Logan syndrome is associated renal issues are there. You will tend to associate it to renal Senior-Logan syndrome, but you test it out, you get the TMEM67 mutation, which is actually implicated in Bardet-Biedl syndrome 14. So this kind of further refining possible if you test it out only. Another example, how the genomic testing will be helpful is that your LCA. For example, you already confirmed clinically it is very neat LCA, but LCA, the molecular underlying mutation can be either CRP1 gene mutation or IQCP1 mutation or IFT140 mutation. So why it is important? But if it is a LCA, molecular underlying cause is CRP1 mutation, that patient is not going to have a nephro-related issues. You can give the reassurance. It is an isolated LCA. But if it is a LCA, molecular underlying phenomenon, is happen to be these two genes, then those patients are progressing to associated renal disease. So, as an ophthalmologist, you can stratify the patients who should be referred at early to the nephro. So that way, you can stratify your patients for the multi-system, associations. But this kind of systemic analysis is possible by doing the genetic testing only. Otherwise, clinically they are classified as LCA only. So prognosis you can better understand. So same way in identifying the syndromic diseases, your genetic testing only will be helpful to understand whether it is an isolated cause or a syndromic cause. For example, many times the congenital cataract and retinal dystrophy may be some of the first to occur. They will end up in ophthalmology clinic only. But by asking them to go early genetic testing, actually you will dissect what is going to come. For example, this neurodegeneration with brain ion accumulation or this NCL and all, very complex neurodegeneration and more progressive disorder will happen. But congenital cataract is this one start to come. They will end up in ophthalmology clinic only, but you may reveal the complexities going to come for that index case. By doing the genetic testing, we may understand the prognosis. Due to want of time, I will stop here. So the AMD is another common complex disorder. For this kind of regular genetic testing is not going to be useful because AMD involves polygenic. It is not a monogenic conditions. Multiple gene polymorphisms cumulatively, along with the environmental factors such as comorbidities and smoking and everything together, will lead to your AMD manifestations. So to look at AMD and all, we have a test called polygenic risk score. Here we can't do the exact monogenic etiology diagnosis, not possible. But what we can do for AMD, late onset AMD cases, what we can do, whether the family has a low risk or high risk, the inherent genetic risk can be predicted. It is a screening test, it's not a diagnostic test. So for any young onset family, positive family history cases, we can undergo this polygenic risk score analysis to understand the current genetic risk to develop, So these are all the tests available. So based on the phenotypes, handles you have at your hand, you can choose the appropriate test. You can go for either targeted panel or whole exome sequencing, or in some of the cases, we need microarray analysis also to understand the chromosomal causes. Gene therapy is available, as you might aware, for RPE65 related cases, although it is going to be very costly, but this is the one FDA approved therapy right now available, to handle RPE65 mutation related LCA cases. This how about giving, blindness person give a vision, which is a miracle. But all these tests to see the light of the day in India might take a lot of time, but this is reported, the established literature is there. Just for your information, these are some of the genetic disorder for the clinical trials are already in place where you can go for a gene therapy. We offer genetic counseling at Mid. I will stop here now. I'll take any queries.
That was a very wonderful talk, Dr. Senthil. Parveen, madam, would you like to share your experience and thoughts, madam?
Yeah, so I think I must congratulate Dr. Senthil Kumar for making it very understandable for us, because I think that is the challenge. I'm sure he could have gone on with the discussion for a very long time, but to make it crisp and understandable is the challenge. So I think it is, as Dr. Senthil showed, that it took 30 years for the first gene therapy to come for LCA in eye. But I don't think it will take another 30 years for the next one to come. The next one is probably going to come much faster, and the next one much faster, and the next one much faster. So I think, and the basis of that, the only way to go forward with it is that we test our patients first. When as you saw, the gene therapy for LCA has come not for all LCA. More than 100 to 200 genes can cause RP. More than at least 25 to 30 genes can cause LCA. Not the gene therapy for LCA is not for all genes causing LCA. It is only for RPE65 gene causing LCA. So you will have to first do gene testing for all LCAs. Then only you will know which one is RPE65. Then only you can offer the treatment, if at all, when it comes to the patient. So that is where we have taken the first step, that gene therapy, gene testing is now available in Agarwal group of hospitals, and that is where we need to sensitize everybody. So there is just one more example I give later on. I think we should do question answers. That even Mr. Senthil mentioned it in his last slide, that there is a gene therapy for AMD. So it's not that we may consider that we don't know which gene causes AMD. How can we have gene therapy? It is because they have given gene therapy, and they have given a chromosome or a gene inside the eye which can continuously go on producing anti-VEGF. So you don't have to give monthly injections. So gene therapy can be very useful in this way. It helps us to understand, gene testing helps us to understand that this molecule, if it is not present, this protein does not form. This deletion is there, this protein does not form. So if externally we are able to do some treatment so that that protein is made available in the eye, that itself will solve a lot of issues. We don't have to develop a gene for each mutation then. Some of the gene therapy are so specific, like for USH2A, which is ongoing, is specifically for exon 13 point mutation. On that only, then only gene therapy is available. So you need to, then only you will understand. And another thing, very important, is that gene testing, genetic testing should not be taken very lightly. It comes with a lot of responsibility. Once you have the report, patients would want to know what can be done. So pre-test counseling, post-test counseling with the counselor is of utmost importance. And as Mr. Senthil mentioned, this is a part of the gene testing services that they would offer, that once they have identified the gene and clinically correlated by the clinician, they can offer genetic counseling as well. It may be physical or it may be virtual over the phone. Yes, Mr. Senthil, am I correct?
Yeah, yes, ma'am. Absolutely. Absolutely, ma'am.
So each testing that you do has to be followed up by genetic counseling, and you can get, once the report will be given to you as well as to the patient. So when you get the report, you will be aware that the report is ready. Once it is ready, it's your responsibility that you will be in touch with MedGenome, and you will tell them that the patient wants counseling, and connect, fix an appointment wherein they can, you can be present yourself. That will make the job even easier. Or the MedGenome people finish the counseling, after which the patient comes back to you for any more queries.
I have a small question, madam. So there was this case where a child of 10-year-old, she came with sudden loss of vision, and there is absolutely no view. And B scan was not much helpful, with the 2 or 3 opinions. Some were opining about retinoblastoma, some like organized vitreous hemorrhage, and endogenous end of all those things. Because if it is retinoblastoma, then the management is entirely different. It has to be enucleated, and there was no way we could do a vitreous tap and do just in case if it is retinoblastoma. So can this genetic testing can help in such clinically dilemma cases where the management is poles apart, and can the turnaround time be shortened so that we can quickly make a diagnosis?
I think minimum, first of all, these kind of cases, the clinical evaluation is very important. So you can do an MRI which will show you a mass lesion. You have to take a judgment saying that whether the eye has a visible potential or it doesn't have a visual potential, whether you would want to retain the globe or you don't want to retain the globe. Finally, the judgment, the decision has to be clinical. You can't just rely on saying that this is RB1 positive, so we enucleate. If it is negative, we don't enucleate. You can't do that. So there is so much more to it. And second thing is that not every time will you get. It is very important for you to understand and for you to counsel the patient. So I have answered in one of the things that the yield is maximum 70%. So if you say give 100 patients for genetic testing, not more than 60 to 70 times you will get a likely pathogenic variant. Most of the other times, either you will get a VUS or you will get a VUS means variant of unknown significance. Why is it unknown significance? Because maybe that particular gene causing this disease has not been described in literature. So once they see all the mutations, they compare these mutations with existing literature, and then they say that, okay, in literature, this gene or this gene variant is going to cause this thing. So if you are going to give them a working diagnosis and a working phenotype, and in the literature also it matches the same phenotype, then only they will interpret it as pathogenic. Otherwise, it will remain. It may maybe the disease variant is there, but will remain as a variant of unknown significance because it has not been previously reported. So in some cases, when you like if you don't know, it's a very mild form of RP. You don't know whether it is a mild RP or it is a post-trauma something. Then you can consider genetic testing, or especially in the younger age group. In the younger age group, this genetic testing is even more important because the disease is all fully developed. It's not fully blown. So you may not get bony spicules of RP there. But the patient may say night blindness. So you don't know whether this is going to be progressive or this is going to be a non-progressive kind of night blindness. Here, if you do genetic testing and you come across a gene, maybe TRPM3, which is known to cause stationary form of night blindness. So you can tell the patient that this is a non-progressive form of night blindness that you are having. But if you come across Crumb's protein, CRB1, or if you come across RP65, then you know this is going to be progressive. Or if you come across what BBS2 gene, you know it is not only going to be progressive, but it will affect the other organs. So you do get a physician checkup done. Even if you cannot save the eye, you can at least save the kidney. Maybe the renal involvement or an inborn error of metabolism. If you are able to diagnose and tell that this is an inborn error of metabolism, it will be life-saving because with modification of diet, with modification of medication, you may actually increase the longevity of the child. So in the pediatric age group, actually speaking, I had a similar patient, senior Loken syndrome. Patient was told chondrod dystrophy, nothing can be done. Finally, the patient came to me recently. She was 11-year-old. By 11-year-old, the child had renal transplant. Because it was senior Loken. It was not just mutation causing retinitis pigmentosa or chondrod dystrophy, but the same mutation caused glomerular nephritis as well, which caused renal failure. If at least we would have known earlier, the child could have, at least postponed the renal transplant to some more years. You can understand 11-year-old and having renal transplant, how much of immunosuppression and everything must be going on for a lifetime. So sometimes these things can be life-saving also.
Thank you so much, madam. So much of insight and clinical application. Anybody else would like to ask any more questions to madam or Dr. Senthil? So I take it as a no. Thank you so much. Thank you so much, madam, for being the and sharing all your opinions.
Lot of questions regarding the cost of the tests and all that. So I can say that definitely comprehensive ophthalmic testing would be lesser than clinical exome or a whole exome because number of genes tested are more. But I think the final integrity will be available to us through our online billing systems, which we have in place. So all of us can look into it and that will tell us the billings regarding the cost, which is why I didn't mention about the cost.
How do we contact the team if we want to do a genetic testing, ma'am? Dr. Senthil or anybody?
Yeah, actually, thanks to MedGenome, they are present almost everywhere, in almost every city. Believe me, I just have to make a phone call and the genetic testing happens faster than blood sugar analysis. So they come to if you have developed a connect, they come to your clinic They come with the whatever they need. 3 to 5 ml of blood is collected. And I think here most of us, I think in our specific cities, I think MedGenome, if you can give us a list of people, one contact number in specific city, that will be very useful, and we could circulate it through our network in Agawals so that it goes to everybody. And that will be very useful. So one point of contact in every city, like in Hyderabad, in Bangalore, in Chennai. I think few places I have already told to the specific people who showed interest. But I think if you do a list of your people who's the one point of contact in each city, and if you share that with us, we can, the DMDA would probably circulate it, and everybody would know. And that would be the best thing. So if you call them, they just come to your clinic. And important thing is they should be able to do a pre-test counseling. They should be able to tell the patient that not in 100% cases you will get a result, 60 to 70%. And that too will depend how good and accurate your clinical diagnosis is. If you are not sure whether you are looking at Stargardt's or RP, or whether you are looking at pattern dystrophy, or sometimes you will not get it if your clinical phenotyping is not correct. Genetic testing is not a replacement for clinical ignorance. So that has to be very important. Phenotyping has to go hand in hand with genotyping. As I'll just give a common example to most of my students, whenever you do an ultrasound or you see an MRI report, it is always written below, correlate clinically. Genetic testing is no exception. You need to know clinically what you are looking at, and then only the whole thing will make sense. You cannot use this as a replacement for your knowledge that you cannot diagnose the patient.
Yeah, yes, ma'am. Just to add, regarding this point of contact and the sample collection, yes, ma'am, as madam said, we are there. Our team is there in all the tier 1 and tier 2 cities, and tier 3 cities also they can organize and coordinate. I will take this and I will align our business team accordingly, ma'am. Internally, I will escalate and I will align it. So that is available to all the chain of Dr. Agarwal Hospital. Also, as Madam said, the clinical notes is very important for us also to understand and pull out the relevant gene and variants. So those are called as human phenotypic ontology terms. This HBV terms are important because under one HBV term, we will be looking at hundreds of genes actually. If you miss one crucial preclinical findings, which you have done at your clinical level, or any biochemistry findings, we will be missing at our end hundreds of genes. So the proper clinical notes is inputs is important for us also to get more valuable output information when we report it back. Otherwise, we will end up saying that no pathogenic variants found.
Yes.
Actually, in the data, there may be one relevant finding might have been there, which we may not have looked at it because of lack of clinical indications to importance to look at that, scan that gene variant particularly. So in the data, that gene may have been there, but we may not have reported. So your clinical notes, preclinical findings, as Madam said, it's very, very important for us. And we give utmost importance to that in our analysis while doing the analysis in the back end.
So the same example that I was telling, the senior Loken syndrome, the most common disease, genetic mutation causing it is CEP290. So CEP290 was seen, but the MedGenome had reported it as VUS, variants of unknown significance. But when I had a discussion with them, that I'm suspecting CEP290 and it is senior Loken syndrome, and the child has got a renal transplant as well. So this has to be pathogenic. The result was actually modified after my clinical input, and it was modified to variants of clinical significance. And CEP290 was the target gene. So, it goes both ways. It goes hand in hand. So you have to keep going back and forth, work in coordination with your geneticist. And initially, if anybody needs anything on it, I'll be more than happy to help in any particular case. Not a problem.
There is a query for risk prediction for retinitis pigmentosa. It was there in my presentation. Due to lack of time, I didn't show that. There is something called carrier screening, ma'am, we are doing. in asymptomatic parents actually. So the characterized recessive retinitis pigmentosa can be appropriately predicted if we do the asymptomatic individuals carrier screening. If both the parents are carrier for some of the characterized retinitis pigmentosa genes, then we can tell them to go for a prenatal testing, and thereby we can avoid the offspring having from the retinitis pigmentosa. So whenever there is a consanguinity is there, this carrier screening testing is optional, and most of the ophthalmology disorders are recessive conditions, characterized ophthalmological disorders, which includes subtypes of retinitis pigmentosa. So we can do the testing even before the manifestation also. It is generally offered to, if you ask me, the parents who are planning to have the offsprings, who are worried about, genetic conditions because of the consanguinity, or their cousins, direct cousins, having a child with that case. So this couple in question would like to test it out, they can go for it. So those kind of screening are called as carrier screening. It is possible to predict the characterized well-established retinitis pigmentosa and border Biddle syndrome kind of conditions. Actually, it will be useful to direct them to go for appropriate prenatal
So
testing.
I don't know whether that is what Mr. Senthil said is absolutely right, but the only thing is that a little bit on the ethical issues. So some diseases have been marked by the government of India that they allow termination of pregnancy, but not all of them. And I'm not sure if RP is one of them. So, because it's an ethical issue, if it is BBS, it is got to have multiple. Child will be mentally retarded. Child will have kidney problem, various things. But RP, otherwise the child is healthy. So whether you can just terminate a pregnancy because the child is not seeing, I don't think we have reached a stage where there is any consensus on that. So so this is something which still you will need to counsel, and they will have to discuss with their gynecologist and various other things. So this is something which is ethically not yet very clear. Am I right?
Yes, ma'am, absolutely, ma'am. There are certain clinical conditions
yeah.
which are manageable. For example, in thalassemia cases and Duchenne muscular dystrophy cases, we helped the family a lot actually, because the family, they are in a persistent blood transfusions when they have one boy already severely affected with thalassemia major. We actually help them to take a proper reproductive decisions. Whereas some conditions like G6PD deficiency, which are clinically manageable, so we tell the patients, parents about the implications, and we are mentally, preparing them to receive such a child. So some of the nasal bone defects, skeletal dysplasias, which can be corrected by surgeries actually. So those times we are telling only the implications. We never involve in the decision making. That is a clinician decision along with the parents. So choices should be, of course, given to the parents finally, with the implications known to them. If they are mentally prepared to receive and manage those conditions, it's fine. If they want to terminate, if it is a severe condition, pediatric onset, severe multi-system conditions, of course, the options are available for them in discussion. Of course, after proper counseling.
Another example, I think, is the FEVR. So sometimes neonatal FEVR. If you are able to find out the gene, you can ask for immediate termination of birth and the child within days of birth, and that may be again side saving. So knowledge is sometimes useful and important. So there are many examples. I think we can go on. At least
Yes,
I can go
there's
on
so many
talking.
examples.
Just one
But,
last question,
yeah.
Doctor. Do you offer any kind of genetic screening for potential parents without any obvious history of consanguinity or genetic conditions in the family?
Yes, ma'am. Yes, ma'am. Nowadays, actually, we are trying to create that level of awareness, but due to, Indian market is a price constrained market. So we are keeping them as an optional. Definitely, the carrier screening, what I mentioned, we are screening for 2000 recessive genetic conditions. Just looking at instead of looking at your planetary positions of where Saturn and Guru stays, you can look at your genetic gene positions. So that you can, avoid a lot of multiple genetic conditions. Actually, that's what we are trying to create, that level of awareness. Yes, ma'am, the carrier screening for established characterized recessive conditions, it is available. It is 2000 something conditions actually. We are doing that. It is available to all the parents who would like to undergo that.
What is the approximate cost for that?
Around 15,000 ballpark, but I would leave this to our business team. But it's kind of like that, ma'am. For one patient. If you do couple, it will be around 30,000 rupees effort.
So that is what he had mentioned, trio clinical exome testing. So trio means the proband or the effective target person involved and the parents. So when you do all three together, I think some kind of financial benefit also comes. So it is called trio, all three can be tested.
And can the parents themselves like voluntarily get tested, or should there be an advice from the treating physician? How is
As
it?
of now,
Self-testing?
yes, ma'am, I got your question. As of now, we are keeping it through referring clinician only. The clinician can be any specialty actually. Most often, this request comes from us through gynecologists and fetal medicines. As many times, the parents are counseled by them only. So, but any clinician referral basis, we are doing with proper genetic counseling. As of now, we are not opening this to direct to customer test. But over the period of time, of course, in some Western European countries, they are offering this as a DTC test.
Okay.
But in India, we are trying to keep it because some kind of awareness and education is needed actually. So we are routing it through clinicians actually with proper counseling. And most often it have to be fetal medicine specialist and gynec specialist.
See, mostly I personally, given the Indian scenario, it is best that they don't know who is responsible, mother or the father. Otherwise, you don't know you're breaking the law. So, sometimes you have to be little sensitive. So
yes, ma'am. Yes,
you
ma'am.
have to think about all these things before you order the test.
Yes, ma'am.
So,
Thank you so much, ma'am.
Yeah. Thank you so much for the session.
Thank you.
Thank you so much. Thanks for the participation.
Thank you, Preethi
Thank you,
and
madam.
Dr. Saraswathy for the efforts. Thank you, Preethi and
Thank
Saraswathy.
you, madam.
Thank you.
Thank
Thank
you,
you,
madam.
Dr.
Thank you,
Saraswathy.
Dr.
Good evening.
Yeah,
It's a
thank you
great
very much,
talk.
ma'am. Thank you all respected faculty members.
Wonderful.
Yeah, thanks for giving
Thank you.
MedGenome as an opportunity. Thank you.
Sure.
Thank you.
Thank you.
Bye bye.